I would like to describe our research where we used a pH sensitizer that can improve cancer immunotherapy treatment as monitored with acidoCEST MRI. I have no financial interests or relationships to declare. First, I'd like to describe how acidoCEST MRI works. We have a contrast agent that has an amide proton. When this amide proton is selectively saturated by RF frequency, the proton loses its coherent MR signal. When the proton exchanges with water, now the water looks like it has lost some of its coherent MR signal. When we do an experiment where we place iopamidol in this inner tube relative to no agent in the outer tube, we can then selectively saturate a series of MR frequencies, and once we reach 5.6 ppm, the inner tube will start to go dark, which is the CEST effect. This happens at 4.2 ppm when we selectively saturate the protons in blue within the agent. And then we directly saturate water in the inner tube and outer tube at 0 ppm, and the entire system goes dark. And we take a symmetrical spectrum that improves data analysis. There's several ways to analyze acidoCEST MRI or CEST in general. We prefer using the Bloch-McConnell equations to fit to the CEST spectra, which include a term for the chemical exchange rate, which is related to pH. Now, this agent is particularly interesting because the peak at 5.6 ppm disappears as pH increases, while the peak at 4.2 increases due to the differences in chemical exchange rate of these two protons, which can be used in a ratiometric method to measure pH. However, again, we prefer the Bloch-McConnell equations, which are more sophisticated. We're interrogating tumor glycolysis, where pyruvate is converted to lactic acid and then secreted from the cell. And there are other mechanisms that also improve the extracellular tumor acidification. So this has been verified with a variety of in vivo studies that we've performed over the years. So we've been studying a pH sensitizer, esomeprazole, that can reduce acidosis in a 4T1 tumor cell line, as shown by this in vitro data right here. Esomeprazole is a VATPase inhibitor and works better at reducing pH, so therefore is a pH sensitizer than the other inhibitors that we tested in this study. Esomeprazole does not cause toxicity against the tumor cells and also is not toxic against T cells. T cells continue to divide when treated with this drug. In vivo, we see that esomeprazole followed by immune checkpoint blockade combination antibody therapy 1 day later does improve tumor control. It also improves mouse survival. It improves the immunogenicity within the tumor as evaluated with flow cytometry. And then this data point here that shows the improved tumor control, smaller tumors when we give the combination therapy, is representing a number of mice. And if we show each of those mice in this plot in the lower right, those individual mice that had high pH after giving esomeprazole had the lower tumors, and those mice that had low pH and was not so responsive to the esomeprazole had less tumor control. Tumors continued to grow. Therefore, we can identify individual mice and hopefully individual patients who are responding to esomeprazole. We tried the study with B16F10 cells, which did not work as well. They're not as responsive to esomeprazole and do not decrease their acidosis, their acidity in vitro. Esomeprazole is non-toxic against this tumor cell line as well, though, so that's encouraging. That's reflected also in the in vivo data where there is a decrease in the tumor growth rate, but it is not significant for this combination therapy relative to other therapeutic regimens. And there is still an improved mouse survival with this therapeutic regimen, but you can see it's not as drastic as what we were showing with the 4T1 cell line. There is an improved immunogenicity when we do the combination the immunotherapy. And once again, if we break apart all the mice within this one data point, we can show that there is a relationship between pH and tumor growth. However, it's counterintuitive in this case for the B16F10 tumor model, where a decrease in the tumor pH due to the drug actually causes less tumor growth. An increase in pH allows the tumor to grow, and that's counterintuitive. So in summary, The esomeprazole is a good pH sensitizer for 4T1 cells, but not for B16F10 cells. The combination therapy reduces tumor volume in the 4T1 model, but not in the B16F10 model. And again, a well-correlated change in pH for the 4T1 model, but not for B16F10. So this shows promise, but not all tumors are going to be uniformly affected by the concept of a pH sensitizer to improve immunotherapy, as shown by acidoCEST MRI. I would like to thank our research group and our funding sources, and especially Dr. Renee Chin, a recent graduate who is responsible for inspiring and performing this work. Thank you.